inform the public debates around key issues in Kenya's economy and social policy. Now, I think it's about 3 months now since the WHO declared the COVID-19 emergency as a pandemic. And in that time, a lot more knowledge has come out about what is required for society in general, different countries to respond, and how to respond clinically through other forms of policies, but also one form of management, all forms of management that would allow for society to life to be restored to the extent that is possible. And so while this started entirely as a crisis, obviously the evidence shows that it might have started some place in Asia. It's now become a pandemic in the sense that every country is dealing with it and responding by some policies. Now, if you look at some of the evidence that has come out, it's clear that this is an illness. Obviously, COVID-19 is an illness that is caused by a virus. I think that is not questioned. And many of the ways in which governments have responded is through trying to suppress, which is basically cutting off public interaction that would lead to spread. But what that has led us to is that in many cases, people think that the ultimate end game, basically, game plan rather, is to get vaccines to work. And so that when we have those vaccines over time, it'll be possible for everybody to go back to work. And obviously, vaccines represent one approach which allows for people to not only restore life, but to bring to back safety, restore safety to the extent that is possible. So in that thing, of course, in that process, obviously, there are many processes that come through before a vaccine gets to be used all the time from its production. Now, the IEA saw in the public discussions in Kenya that the question of testing itself is one that's just fraught with not only controversy, but also one in which our assessment is, and we are speaking as a public affairs institution, the public understanding about the vaccine production process, the testing, its deployment and regulation in general has been insufficient, as we see. We say that with respect. So what we'd like to do today is to get a number of professionals, one, biomedical professionals and researchers who work in this area, to give us some highlights and to foster discussion for us, helping us to learn and to the extent that is possible, inform the public who are listening about what are the protocols that go with vaccine production, how is it regulated in Kenya, and whether there are any peculiar risks and how those risks are managed throughout the pipeline of production of vaccines and their deployment. I think the most controversial thing is that the public in Kenya responded quite aggressively to the view that I think an unguarded comment from some 2 French doctors suggesting that vaccines should be tested in Africa for their own reasons, which inflamed public opinion, but more importantly revealed the fact that knowledge generally about science is something that I think the demand is there for, and to the extent that is possible, we are trying to host this discussion to create that. And so we have today 3 presentations. The first presentation will be made by our colleagues from the IEA, Leo Kamboi, who's an assistant program officer at the Institute of Economic Affairs, and he'll just be talking broadly about what is the economics of vaccine testing. I mean, people might argue what's the economics behind it, but obviously any endeavor that requires resources must address some economics issues. And thereafter, we'll have Dr. Wanjiru Njugi, who will discuss the bioethics of vaccine development. And we're also privileged to have Professor Fred Were, who will discuss processes and regulation of vaccine testing and administration in Kenya. So without further ado, thanks for all being here. We have 20 and a bit. Thank you very much for taking your time to attend this. But I'll open up and I'll ask Leo in 15 minutes to take us through, Leo, 15 minutes, no more, take us through the presentation on what's the background, what's the economics of vaccine testing, development and distribution. Leo, go ahead.
Yes, good morning, everyone.
Good morning.
So my presentation will be now to look at the history of vaccines, so the development so far, the demand side, the demand and supply side economics, and how vaccines it's the challenge, the vaccine options and challenges in vaccine production, and now the key policy takeaways. So, as we all know from history, that the first vaccine was done by Edward Jenner on smallpox in 1796, and what they were doing is they're taking material from blister of someone who is already infected and inoculating it on the skin of another person, what medics would call arm-to-arm inoculation. So the development so far, now based on the reproduction, the rate of infection of coronavirus, the SARS coronavirus 2, and now the lethality, how little it is, the vaccine development process was accelerated. Most of the regulators, like for example the FDA, the Federal Administration, lifted restrictions, which is basically government rated on the timelines, how the vaccine is regulated, so that they can encourage. It's a form of incentive, so that they can encourage most of the research firms, to go into the development process. Now, we also know that the mapping of vaccine candidates ongoing. Some of the trials in animals have been successful, and some of them are moving in vitro. We've seen an example is the Moderna farm, which already has published results on the latest on some of its findings in the clinical trials. So by May of 2020, WHO reports that 10 candidates are in clinical 10 candidate vaccines are in clinical evaluation. To look at the economics of the demand side of the vaccine tests, well, first we need to know that both the vaccine and the vaccination program is a public good, which means that you cannot. It's non-rival and non-excludable. Everyone, until you have to vaccinate until you're able to get that herd immunity, and perhaps more. So, if you're vaccinated and you're unable to infect others, in economics, that's a positive externality. So part of what should happen on the demand side is the regulators. This now is the state, and in particular the Ministry of Health, is that there are approaches on how to make sure that everyone is able to be vaccinated. So there is the traditional government approach, which is the command and control approach. Those are directives that now everyone should be able to. You must get vaccinated, for example, to return to work or go to school. So the normal government directives, those are the ones that governments use to ensure that everyone is vaccinated. On the market, but what we are proposing, and this is the most popular in economics, is to use incentives. Some of them include tax. It could be either a tax or a direct incentive. This includes cash. We know that like in India, some of the things that governments used to do is, for every child, if a child is vaccinated, they would give the mother things like lentils. This ensures that you are compensating for the cost. Everyone is able to bring out their children, or you can use cash incentives. Especially Kenya has a younger population. Our demographic dividend is that almost 78% of people are under 40 years. So you can use cash. Let's say everyone who goes to be vaccinated would get 1,000. Now, let's discuss the vaccine production on the supply side. The vaccine on the process of the research, the trials, the animal trials, the human trials, all the way to getting the vaccine, and also the production, the costs are very huge. It's a very capital intensive process. There are also several regulations that farms have to ensure that they're able to get before they get the final vaccine. So, and also in here for the coronavirus too, there's some form of market uncertainty. One of the things is that some countries could attain herd immunity. We know, like for Sweden, there are estimations that by June they have gotten the herd immunity. And also the SARS coronavirus 2 might go away like SARS coronavirus 1. Remember the first SARS coronavirus 1 in 2002, 2003, it just went away. There was no vaccine there was no vaccine that there was no vaccine that the farms were able to get, but the coronavirus went away. So some of the expected interventions is to this kind of market uncertainty because of the capital, the costs of production. Some of them include the market-based policies. We know that there is an advanced market commitment for vaccines that I think it's $1.5 billion that is run by the international development partners. And now other farms, like in the United States, the US are using the Defense Act to ramp up the capacity in research so that they are able to accelerate. They are also lifting some of the regulations that require payments for regulations that add costs are being lifted up. So that is costs being done away with. And also there are subsidies. There are those countries that provide direct subsidies, like Germany. Now, so if you were to have a vaccine in Kenya, what would be the distribution mechanisms? The way we see some of the things that we know is that we know, for example, that an average Kenyan in a year travels 200 kilometers. So you can, with that kind of movement, there has to be some considerations to take into place. You have to vaccinate, especially where there is high population density. This would include places like Nairobi, the metropolis, Nairobi, Kiambu, Machakos. You have to take into consideration that size of population. So also on the ports of entry, some certain professions that handle, like for example, the medics, transporters, you have to also look at the transport corridor. To elaborate this further, we used the map of Kenya. So this map shows the concentration of population. So if you see the map of Kenya, the population is along the southern part and along towards the western part and most of the southern part. So these are some of the places that you have to concentrate your vaccination program along. You can also see along the coastline. Those are some of the places that you'd have to put your vaccination, and mostly along the border points. You can also see at the top, and actually along all Kenyan border points. Now, as we've mentioned, so some of the challenges that we are seeing in the vaccine production, any farm, a vaccine producing farm is just like any other ordinary farm. For you're producing so that you're able to get incentives. You're producing so that you're able to get profits, and this gives a challenge. So if your demand, if your supply goes, if your demand for the vaccine goes down, fewer farms are able to remain in that market. So some of the things that we see is that because the production of vaccine is slow, very expensive, the challenge of imitation, deviation, and competition is also rapid, and that's a very real challenge that is seen now. So another one is on the R&D costs. Most of the farms that have entered, you have to have $40 million and above. So the likelihood of getting such kind of farms, very few farms, and that's why you see most of the farms that are in race to develop a vaccine are in advanced markets. They are not in ordinary per se, like the LDCs where we are. Now also there's the issue of complexity of the market. Most of the things that we read from the media now is that you'll hear a farmer's, for example, published results, but in vivo at the animal trial stage. It doesn't come to the human trial stage. And now there are challenges. Your results, you have to appear before regulators, you have to put up those data. It's critiqued from, and also there are risks. For example, we know that sometimes back there was the South African, there's a South African research team that were doing the study on HIV/AIDS. They stopped the study because their control group, in their control group, they were getting the virus faster. The rate of infection was very big. So these are a complex market per se. Now, some of the things is the key policy takeaways that, so one of the things is to use patents to spur rigorous growth rigorous development of vaccines is use patent. So this is innovation economics. This is to say that if you have a patent, and all these patents are going to be honored across the world, if a small farm is able to get a vaccine for coronavirus, you are guaranteed that they will be returned in all markets. Because so what patents do is you are able to license to a bigger farm to produce. You are able to license to a bigger farm to distribute, and it's an important regulation process. So another one is a faster approval process, and we could see, for example, for Kenya, we know that the Ministry of Health has okayed the Kemri Wellcome Trust to develop an antibody test. Another one is now the funding mechanism. So there are various proposals on how to ensure that the funding is available for farms, and including those ones like, for example, the Kemri that have now Wellcome Trust that now want to develop an antibody test. Is there, so they could be the international cooperation using the incentive mechanisms. Now there are auctions. And then another thing is to ensure that we produce key inputs to avoid supply contagions, e.g. the glass vials, the syringes. What we've seen in the past 3 months is globally, because of the rush for medical gear and other equipment, that was required for coronavirus, there has been a supply contagion for things that include, for example, masks, that could be as simple as masks. So as we think about the vaccine development process, there are things that also go with vaccination. Some of them, like glass vials, those are critical. So we have to be thinking ahead in production of this. So that's the end of my presentation.
Okay, thank you very much, Leo. So Leo's taken us through the demand and supply sides of economics. He's reminded us that he has reminded us that that a vaccine production and distribution, or rather the vaccination process itself, is a public good. It's a public good in the sense that when you control for diseases, obviously it benefits more than just one person. So that's what an economist calls something with positive externalities, in the sense that vaccination delivers better public health, and that's in itself a public good. On the other side, on the supply side, we know that it's very capital intensive. And by capital, it doesn't just mean money. I mean, what it requires in terms of labs, the investment that is required to generate a vaccine has high risks, but it also requires significant capital input to get out your, to make the investment pay even before, rather to get the vaccine, a successful vaccine, even before the investment pays. Then there are regulatory burdens and barriers, which I think our next two speakers will speak about more medically. But I think what Leo has demonstrated for us is that even when you think about it as an input into the public health service, I mean the public health pipeline, there's a value chain into production of vaccines, and there are some laws of economics showing why demand is as it is and why supply is as it is as well. In addition to the fact that producing a vaccine, which is a product, requires that you consume other complementary services and products. So for instance, we know that vaccines have to be produced in certain conditions, they have to be transported in certain conditions. So obviously, if it's a value chain, it's a cold chain that is required to make sure that the vaccine is available, then obviously that affects the ability to distribute it and to distribute it cost effectively. And he concludes by saying that because of the nature of that public good, it's very difficult. And one of the things that governments can do, because of the risks that private firms would face, one of the things that governments could do is to actually try and incentivize the production of vaccines. And obviously he spoke about the money that global conglomerations have put together, whoever it is, trying to make sure that the race towards the production of this vaccine comes much quicker, sooner than later. And that will be for the benefit of all of us. Thank you very much. So now I'll go to Dr. Wanjiru Njugi. And he'll be talking to us about the bioethics of vaccine development. He could introduce himself and his title, but Dr. Wanjiru Njugi is also a biomedical researcher, and he understands all this. So he'll be talking about the bioethics of vaccine development, testing, and its distribution. Dr. Wanjiru Njugi, go ahead. You have 20 minutes.
Yes, good morning, everyone.
Good morning.
Yes, my name is Dr. Wanjiru Njugi. By profession, I'm a pharmacist, and I'm currently doing a PhD in public health. And I can say I have very deep knowledge in research, but I have done much. So I'll take you through slowly so that we can try to diffuse so much of medical terms to the more of English. So I want to start with of course, the first definition here, you can see it's economics, which is the study of how society uses its own limited resources. So this is quite self-explanatory, but I want to go a little bit to the health economics, where here is the one of the resources in healthcare is the human resource, and also the other resource is the finance, which are going to fund, and also equipment we should be using. So then I want to talk a little bit about bioethics, and although I'll go detail further when I go to ethics, the bioethics is the medical or biological research code of morals or values which govern us as medics, because we have an upper hand of the knowledge of health over our clients or patients. So what ethics that help us or help the patient to feel that he is confident to be able to approach a certain medical or medic. An example is what we call the Hippocratic Oath, or the code of morals we use in research. A vaccine, you have seen, is just a substance that stimulates the production of antibodies, which we are all discussing here. Then you can push next. Yeah, so the vaccination overview. Here, I want to mention that in the previous slide you have seen, I was talking about ethics and vaccination. Then Keboy discussed previously when it started and how it started the smallpox. And one key thing I want to discuss in detail is ethics. The ethics here in vaccination overview is whereby, and I give an example before I continue, there was a drug called Melarone, was supposed to prevent what we call prophylaxis of malaria. The research was being done to the people who has the malaria, not people who doesn't have the malaria. So there was that controversy whereby the people felt like, why would you test us whether the drug can work when it will not be used on us? So you see, when people start feeling like they are being outplayed, or they feel like someone is doing something is not favoring them, that is, to them, they feel that the ethics are being played out and they might not participate well. When we, at the end of the day, what we need is a vaccine, and that we require people to be able to accept to be enrolled into the research so that can get the vaccine faster. So vaccine is one of the great public health achievements of human history because it has saved so many diseases in our life. Vaccine used in immunization program are considered safe, as we shall talk in detail in later, because there are certain guidelines that are set to make sure that the vaccines are safe, they are efficient, and they can produce the required results, as we have said. They have adverse effects, as usual. Anything that you consume, including food we eat daily, if you consume it so much, it has side effects. That's what we say, everything is poisonous if you take it too much. So it has side effects or adverse effects, which we can also mention later. The public trust in vaccine safety is key to success of a vaccination program. Yeah, that's my baseline or foundation of this training, whereby that if we don't have ethics and we don't have trust and respect towards both sides, the organization who is doing the research and the people who are taking the research, so that we can have all the results. If the trust is not there, that can have an issue. You can proceed. The importance of vaccines, like I said in the previous slide, that we cannot emphasize how important vaccines are because we have seen it now. And even the current information or the trend that is going about the vaccine for COVID-19, it's how we can all end up having a herd immunity. And I'll say that herd immunity, away from the science term, is whereby that majority of the population, probably over 90% of the population, are vaccinated. For example, now the tetanus toxoid vaccine, that the tetanus bacteria or the microorganism cannot be able to invade anyone because it has already been, the public has already been immunized that this bacteria cannot have a host. So that was calling a herd immunity. That in COVID-19, the virus, if you have the vaccine or the majority have the vaccine, the virus cannot have a host to invade. That is what you're calling herd immunity. So at the end of the day, we push it out of our systems. The vaccine has an expansive reach. That is good because you see, once you immunize people, the majority of the population will have it. The vaccine has a rapid impact. That's also that's whereby you see at birth we usually give the small children or the small babies, the first vaccine they get is BCG, which you can see take effect as early as possible. The vaccines are save life than cost. Actually, the key word here is the impact of economics. So we have seen that once you immunize, you end up having we save life and you reduce the cost. You can proceed. The impact of vaccine, I don't want us to get confused between the importance, the impact, because the impact is what the vaccine is doing to our lives. So we reduce deaths among children under 5 years old, which was key for the MDGs and SDGs, that is Millennium Development Goals and Sustainable Development Goals. We have seen that one of the key component of these MDG and SDGs were to reduce the deaths in this other age or under 5 years. So vaccine has really worked. It provides protection against life-threatening diseases like influenza. Yeah, we have seen there was a timeline a while ago there was influenza outbreak, and actually you can see that the vaccine really saved these outbreaks. There is more funding to vaccine production and more job creation. So what he's saying is once like now the COVID vaccine production, which is happening, it's also creating job, because you have even our local systems, that is Cambry has really in the last few days have really advertised for the jobs for the scientists so that they can be able to facilitate this production. There is reduced disease burden and disability from these vaccine preventable diseases, whereby we're talking about most of these vaccine diseases, for example, polio, they create disability. So once you vaccinate, you reduce disability among the society, and then you can have healthy people. Then we reduce hospitalization cost. The cost of a vaccine versus the cost of hospitalization cannot be compared, because hospitalization, of course, it has other expenses, not just the cost of being treated, the diseases, and the hospital stay. It also have a cost of time. You see, you are admitted, you're not able to work. So at the end of the day, there is those other costs that comes together. Yes, you can proceed. The barriers to immunization. One of the point here is that lying weakness in the health system in many developing countries, like in our setup. When we were discussing the previous Keboy slides, we saw that one of the issues will be the transport corridor. So that in our and also our system, how we have grouped our systems in healthcare system, whereby when the vaccine arrives in Kenya via air or water, before it reaches someone somewhere in Lodwar or somewhere in Kiambu inside the village, we need to understand that vaccines are delicate. They are affected by temperatures, humidity, all those environmental factors, they affect them. So their transportation or their distribution is not just about like any other products. So they require critical timelines and also measures to make sure that whatever came in from the manufacturer is what is going to be given to the actual person on the ground. There is also difficulty in delivering vaccine due to poor logistics. I think I have emphasized on the other top. There is also low understanding of importance of vaccines. I think you have heard from the media that there is a group of people who are trying to spread that vaccine somehow. Some of them are not safe, which, like I said before, they also have side effects. So if someone can concentrate on the side effect and start spreading unintended or unfounded rumors, that one can spread scare and also make people not really take serious about vaccines. There is threat posed by unsubstantiated rumors, which are also there, and then there is projected shortfall in funding to the vaccine production. I just want to mention, I was reading an article somewhere in the online, and it was saying that most of these billionaires or the big people out there with good money or donors, they are now not very consistent in funding vaccine because they don't have big returns. I'm very sure the economists will explain better, because what they're saying, vaccines is one-time treatment. Unlike something, for example, a drug you're using for example, high blood pressure. So in this drug, you'll be using it every other day till probably your lifeline, because it is a chronic disease. It's a disease that will stay with you. But a vaccine you're given at birth probably, but you don't use it anymore. So when we say, like in economics, when you fund a project of vaccine, its returns are lower than you do with other things. So that is the problem, that most of these organizational manufacturing companies, which are international, are not concentrating so much on vaccine over other productions in medical. Yeah, we can proceed. Economic sense, I think I've just highlighted very fast. The vaccine creates immunity. We have seen that it has a long-term positive effects. That is true, because once you immunize at birth, you have that lifelong effect until your body have issues. I want to just say, like, until your body develop immunity problem. Like now you develop a condition which can create your immunity to go down. An example is kidney failure. Another example is cancer. Another example is HIV and AIDS. Those, they will lower your immunity, and the vaccine you're given might be a little bit or somehow be altered, and you might end up having being infected by some of these diseases, especially like, for example, TB. It reduces hospital visits. We have seen that. It makes healthy people stay safe. And I just want to mention that most of the vaccine are given to the healthy people. So when you give a vaccine to a healthy people to stay safer, it makes the economic sense, because now what we need for COVID is us to have a vaccine so that we can be able to go back to our normal life without looking back who look like he can be able to cause a problem to us. It creates herd immunity. I mentioned that. The prevention cost is less than the treatment. That I cannot emphasize in detail. As you can see, it's cheaper. The quality of vaccines globally, WHO has taken this role to make sure that the vaccines which are distributed globally are well accredited. Although we have national regulatory authority, like in Kenya, we have Pharmacy and Poisons Board, or in other countries, like in America, they have FDAs. So the quality of vaccines, which is WHO and UNICEF has collaborated to make sure that they are safe. So they also provide long-term protection. That's one thing. They achieve immunity in a minimum number of doses. I just want to mention that maybe someone have read about the current details of the COVID steps so far they have gone. And they have one of the mention is that they are when they are doing their clinical study, because this is a first phase of the vaccine of the COVID, that means they have left the preclinical and then they are in clinical. So preclinical means these are research which are studies which are done in laboratories, or they are done to the animals. Then once they ascertain that this vaccine is working or it's effective, they can now come to human. Now in human is what we are calling clinical trials. And then in clinical trials, you have number of phases, phase 1, phase 2, and phase 3. So when we talk about protection, number of doses, is that during that study, they'll inoculate. Inoculate is where they induce or they just give. There is people who receive small doses. Some will receive a moderate and others will receive a high doses, so that we can all see what are the impact when we give the different doses to different people, so that we can have the optimal or the correct doses. That is also minimal correct numbers of doses. Then cause no or mild side effects or adverse effects. That is one thing. Then stable at extreme conditions, because you say that most of, like in our setup in Kenya, vaccines, we receive them from international. So the conditions for these vaccines has to be good, so that they can be able to sustain that timeline from the manufacturers in international setup to our local setup, and also to even that person somewhere in his village. Available for general use and through mass production, affordable to the population at risk for infectious diseases. We have said about affordability. Yeah, so now we can proceed. The adverse effects. I just want to take a little bit of a time to explain the 5 points so that we can be able to have a better view. The vaccine adverse effects, I've divided them into 5 types. One is where the products. Now, this is the vaccine, the COVID-19 vaccine. So this vaccine product could have an issue. So that is why they started with animals before they come to us. But maybe there's something they didn't look clearly. So once that product is given to human, it affects you. And that's why I'm giving an example of lip swelling. So because after giving an injection, your body swell because it's reacting to that. Vaccines are antigen. An antigen is something which is you're giving to your body. But also the vaccines are protein-based. So when you're given to your body reacts. Like how you hear someone say, he reacted to a certain protein, he reacts to eggs, he reacts to anything, all those. Then we go to quality. In quality is where the product is effective, but its quality can cause problem. For example, it can be contaminated during production or during transportation. So its quality is low. Then it ends up creating a problem. Like, for example, I give an example of paralytic polio. A study was done back in 1999, whereby they found that some certain polio vaccines were contaminated, and then they created problem. That's why they receive those priority issues. Then there is poor vaccine handling. Way back in Kenya, I can't remember the exact year, but I was trying to look at it yesterday, somewhere in Western Kenya. There were kids who were given some vaccine and it was in the media. And preliminary results were showing that the issue was how the vaccine was being handled. So handling of vaccine, we are talking about it's storage, because it's supposed to be kept in cold chain, most of them. It's administration, that is the nurse or the doctor who is going to give the vaccine, and also the route. The route is whereby we are saying that if a vaccine is supposed to be given via a certain method, like now it's supposed to be given into the muscles directly or into the skin, what we call dermal, and then you give the other way, you can have problems. That is what you're calling handling. Then there is anxiety. Anxiety is whereby we have seen adolescents, especially this timeline of previously before COVID outbreak, there was continuous vaccination of young girls aged 10 for HPV virus vaccine. So those age, they might fear injection. Of course, most of the majority of people don't like vaccines, injection. So you can inject and the person faint. So or have other side unrelated reactions. So this reaction is not because of the vaccine, it is because of the event. They are feeling anxious because of the event. Then we have the coincidental. The coincidental side effects whereby the kid already was developing malaria or was developing pneumonia, but he or she has come for the vaccine. So when you give the vaccine, the body reaction to the vaccine plus the redeveloping or pre-existing disease, they come together. So the mother or the guardian present like the baby is developing issues, but the issue wasn't the vaccine, was the coincidental case. Yes, we can proceed. The stages of immunization, just move to the next point so that I give an explanation. Yeah, in this stage, you can see the first stage is where we are now with COVID. We are all in pre-vaccine stages. So the disease is high, it has high mortalities, it has high morbidity levels. Morbidity is how the disease burden to us. So you can see there is big numbers globally. Then we shall go to the next stage whereby the vaccine is found and the people now are getting the vaccine. And you can see the shoot of the line, the vaccine coverage is going up and the disease line is going down. So then this will take us to that stage whereby the side effects of the vaccine were there, but everyone wanted the success. So nobody was concentrating, or even the data was not concentrating on the side effect, it was concentrating so much on how the disease is coming down and how the vaccine is working. In that stage, it's where now you get that the people, the disease is gone, or almost to zero, and then people now still have the side effect. But some side effect or adverse effect, they are prolonged, they take longer. It's not just like the fever, some take longer. So now there is that surge, or there is that climbing of side effects, and the people will now concentrate on the side effect, and this create the confidence. The confidence of the vaccine goes down. People don't want the vaccine anymore because now the data has started picking that the side effects are more. And then we go to the fourth stage, whereby the disease will climb up again because the confidence of the vaccine has gone down. Then, and finally, the resurgence of the vaccine, which now people accept again, and the outbreak goes down, and the disease probably become eradicated or just goes down to almost zero. Now we can proceed. The sustainability of vaccine or vaccination globally, the CDC 2010, I was reading that data and was saying that one of the key points is to monitor incidences of adverse effects following the immunization, that IEFI, that was I'm calling that adverse events following the immunization. Then there is scientifically evaluate the likely associations. Then there is response to the newly identified risk from the vaccines and communicate the benefit over the risk to the patient. So what we are saying that for us to sustain this is we have to speak more how the vaccine is better, as long as the side effects are kept down and economics are making sense to us. so that we don't give a vaccine which at all the day doesn't give an outcome which is positive, rather than there are more side effects or there are more sounding side effects. I usually give this example. When a side effect happens to an individual, and then we classify ourselves into individual. If you're saying 1 out of 10 has side effect, now we start counting the 10 into the 100. So at all the day we have 10. So if we consider this 10, that sample population is totally affected. That is what we have to respond the newly identified risk for the vaccine, so that it can also make sense to everyone. Now we can proceed. The stages of vaccine production. Like I just mentioned, there's two stages, and then there are a number of phases. The first is a preclinical phase, whereby these are what you had Kebo was saying about in vitro and in vivo. So these are laboratory work, more of laboratory setup work, whereby in real time, we take a sample of the microorganism which is in mentioned, like now the SARS-CoV-2 virus, whereby it is inoculated to a certain animal, and then the animal will develop the antibodies. You can give, or we can expose that animal to different doses. Once the antibodies gotten, then we get these antibodies and we multiply them. Then we test whether their use, their efficacy, their safety, and toxicity. Without much of science, we are just saying that, are they working? Are they safe for us to use? Or will they cause any side effect? Or how much will it cost for us to be able to produce? That is the preclinical stages. Then we go to the clinical stages, where now the COVID-19 vaccine, it's in phase 1, where they are testing in small numbers, and they are saying there is positive impact. So the next phase, they will go to the clinical study for the people who has characteristics and those who don't have, what you're calling a control. So they will do people with diseases, those without, and then they compare the notes. And finally, they can say now the vaccine is safe. Let's now try to the masses. Now we can go global. And then the registration of the vaccine follows later, and notes to follow. You can close it. Bioethics, because I said those were my foundation of these slides, is a concept that is guiding us to choose what behavior help or harms others. So when you are going to enroll for the vaccine studies, we want to make sure that money or political or other forces does not guide you to do the right thing to other people. We want you as a researcher to make sure that what guides you is ethic. The ethics is the basis, that the humanity or the humane part of you that tells you that when I'm choosing the people who are supposed to go to the study, I did it right. I used the respect. I was using the beneficence, and I was using justice. When I'm using those terms in English is whereby I'm saying, when I go down to take sample for my candidates, I must be humane, I must be respecting, and that's where the other terms which will come forward, like the concept of being justice, like you're taking other human, even if they are in the study the right way. Like you mentioned the previous, like some doctors from UK, they mentioned that we are going to test it in Africa. Like Africa has a certain way, the way he was trying to mention. That is not ethic. Ethics is whereby humane leads the point. And you can see the last point I'm saying is the principle of ethics is do not do any harm. And the law will talk about other things that we talk about in law. So you can proceed to that. The ethics about vaccine, we usually look on 4 concepts. One is mandate. Why are we doing the research? Why are we settling to look for the vaccine for COVID? That is the mandate. Does it make sense to expose a certain people to justify a certain concept? That is the mandate. Why are we doing it? The research and the testing is what you have mentioned about the stages of how the research go on and the testing and how we select candidates and why we select them. And finally is the informed consent. The informed consent is a law document or legal document which abide the candidate who is undergoing the research and the researcher, so that both of them can be able to keep respect between the timelines, so the research can be correct, quality, and within the timelines. Then we have finally the term was access issues, whereby now we have seen if, for example, a research is discovered, the research has discovered the COVID-19 vaccine, we might have an issue, especially in our setup in Africa, to be able to reach to the farthest person easier than some country like in Europe, where their own infrastructure is well set up. So that could be the issue of accessibility. Then World Medical Association declaration in Helsinki, our last one was done in 2013. They laid down some guidelines and rules we follow when we are doing the research about how to be able to be respectful, to create beneficence and justice. The health of my patient will be my first consideration. That I don't have to expose the wrong people, because you see there are people in some society, in our society, which are a little bit less fortunate, like now people with mental disability. That's a point we need to mention when we're doing our research. A physician shall act in the patient's best interest when providing medical care, including the research, safeguard the health and well-being and the right of a patient. Then the medical research is subject to ethical standards that promote respect for all human subjects. Like I mentioned, that respect, beneficence, and justice is key ones. Then what are the goals of the research that never take precedence over the rights and the interest of an individual in the research? Here is where you're talking about, you should know, most of the research has sponsors. These are billionaires, they are donors and big organizations. They should never influence the outcome of a research or the protocols. That is where we are talking about money or influence or political interference should never take the precedence of the rights of the interest of the candidates. You can take next slide. The vulnerable group and individuals, these I'll just mention that some of them is some group and individual are particularly vulnerable. Like the study was done for Zidovdin back in 1997, and they were doing to the vulnerable candidates, that is sex commercial workers. And you can see now when you're doing a research trying to impose that the success is for them, that group becomes vulnerable, because to them they feel, yeah, we should have that solution to us first, or it's good to us. So you see, that was not the intended outcome, but that a group that should be protected may have an increased likelihood of being wronged. For example, now mental disabled or children may be incurred additional harm. Like, for example, the drug abusers, if you're doing a research and the drug or probably the vaccine you're going to give might interfere or might create more harm into your body, it's good to be very clear what you're doing. The individual should receive specific consideration and protection. And the medical research with the vulnerable group is only justified if the research is responsive to health needs or priorities of this group. Like I have said, that this group, once you're doing research on them, whatever you're doing, it has to be very specific, useful to them, because that's the basics of ethics. Now we can proceed. Research Ethics Committee. So there are two entities I would like to discuss, as I say, is about Research Ethics Committee or Ethics Committee or Independent Ethical Committee. They have different terms, but all of them is to mean that it's a committee set aside to make sure that the research which you're going to take, it's creating respect, creating justice, and it keep the beneficence of all timeline. The other entity is what you're calling informed consent, which I'll discuss in the next. So the Research Ethics Committee, one of their role is to make sure that the ethics evaluation and approval of the project. They make sure that project is approved and it's within the guidelines that we talked about, World Medical Association or WHO guidelines or international accreditation guidelines. The next one is continuing review of ongoing research. What I'm saying here is that when you're doing a research, sometimes you expect to get an A or certain outcome, but you also, within the process, you get another outcome. So that's why we have to keep evaluation so that we keep monitoring what changes, because our body are dynamics. Our body is made of dynamics that today you see, tomorrow you are better. So we have to keep changing our evaluation within the process. And this body is one that keep us into the loop that whatever you're going to take is wrong or right. And they must be very dependent. The active promotion of principles of ethics through education and training. So they keep training the researchers that this is our new guidelines. We changed A and now we have maybe guideline B. And then we should use C because of these changes of weather, climate, or political, or all those influences that are changing our lifeline. Then we have the approval amendment. They approve the amendment protocols. So during the process of research, you might discover that what you intended to have is not what you're having. So these changes, you have to put them in paper, inform the candidates, and then before you implement them, you have to go to RIC body so that they can approve whether whatever you're doing is right or wrong, or is still within the intended guidelines. So you can proceed. Informed consent. This is whereby candidates are explained that the vaccine, like for example in COVID-19, we have already seen that there is stigma in the public. So when in Kenyan setup, if you want to do this research, you have to explain everything which is of the science importance to candidates so that they can be able to understand that whatever the research you're going to take, this is the outcome, this is what we expect that can happen to you. And in case this happens, this is what we can do to you, or this is what we can be able to do. So that when that person is signing there in that document that I was explained in the terms I understand or in the language I understand, and this I accept to do this research. That is what in simple English is called an informed consent. This document, it doesn't change unless, like we have said, there are changes that can be acceptable by RIC committee. So this document, it's remained that way until research is over. What the point I want to say is that it must respect. So the last point I want to mention is called placebo. Placebo is whereby you're going to give, we have a control group whereby in your research or in study population, you have 100 people. Study population is the number you're going to, your candidates, which you're going to give the vaccine. So in this 100, you might pick 50 or 40, 60 or 70, 30. So 10% of the population probably in your sample will not get the vaccine. They'll get something different, or even okay, I don't want to mention exactly what you can give, but placebo is not exactly what others are getting. So that you can use as a control that when these people are saying, I developed fever, in these other 10, did they also develop this high body temperature, or was it the same? So in those placebo, you have to, and some of these research, they use what you call double-blinded, that the researcher doesn't use a placebo, and candidate doesn't also know, or what we call single-blinded. Single-blinded is you blind the candidate, so you don't tell them what they are giving, but you know 10 of them do not get the actual vaccine, so that you can use them as a control. Then the other 90 can now give the results you intended to do. So placebo, it's a very, very delicate thing, but it's very necessary in science so that you can be able to give the correct answer, a right answer. Thank you.
Okay, thank you very much, Dr. Njeru. So what we've had is basically that vaccine production is guided by very sound medical ethics. I think there are standards and protocols of processes. One of the things that's also clear to me is that, I mean, it's self-evident, but obviously we need to mention is that the use of a vaccine for management of diseases that could spread is actually a cost-effective way in the sense that it saves more money. I mean, or rather, it saves society quite a lot of resources because you apply a vaccine, you're able to protect people from the transmission of disease or actually from the losses that come with treatment. And a vaccine, in many ways, is more cost-effective than treatment, which is a useful thing, in addition to the fact that, of course, it saves very many lives. And then there are processes from the preclinical phases to the clinical phases. We have very solid forms of ethics. And I think the most important one is the question of the informed consent, that nobody participates in the testing of vaccines at the testing stage without their full consent. They have to understand what it means. And of course, there's the use of placebos and how all this is tested. So there's some solid science behind it, notwithstanding the fact that you also concede that I think public trust in the public health authorities and those who administer vaccines or those who give that authorization and regulation are essential. We'll now go to our third speaker, Professor Fred Were. And Professor Fred Were will be talking about the processes and regulation of vaccine testing and administration in Kenya. Professor Were, you can come on now. Please switch on your microphone and your camera so that we may see you.
Morning. I'm not sure there's a good idea to see me, but there I am. Good morning, everybody. Thanks again for inviting me to this pretty interesting to me webinar meeting. Because as a pediatrician, and as you can see from my training, I'm not quite a pharmacist. I'm not quite into biomedical sciences. I am more into the policy side and advocacy. And I thank you for thinking that I could be useful. The economics of things usually don't blend well with pediatricians, and many of us who think we are on earth to save life, not money, but we understand that it's important. I will mention a few things largely around the policies that govern the safety of vaccines in the country. I've noted a few young people online who can do this talk better than me. Jacinta, I can see you are there hiding and there at wow. Just to put us in perspective in Kenya, we have been, as a country, involved in things vaccine development for quite a while. The only early experiments that I'm aware of that have been going on for quite a while now are HIV vaccines at the UN's Gavi Institute, the Kenya AIDS Vaccine Initiative. However, beyond that, we have been quite participant in other aspects. For instance, we participated as a country, or the scientists here and the subjects here, in the phase 3 trial of one of the rotavirus vaccines, which is now in use globally. We are also currently undertaking or participating, including our own researchers, what we call fractional dose pneumococcal vaccine. That means that the pneumonia vaccine that you are familiar with, we're beginning to think if we can use a smaller dose or the smaller numbers, and that's the primary trial. It has behaved just as to the same demanding extent as a new vaccine. And then we're also trying the single dose human papilloma virus vaccine. We have, of course, done other things. We piloted the HPV vaccine earlier. We are currently piloting malaria vaccine and social influenza for children. So we have been in that mix for a while. Quality checks are perhaps what I'll talk about in a bit. We have people who work in the Pharmacies and Poisons Board here, and probably I saw a name from the Public Health Lab, might throw in a word or two if they can. And that's the area that we are. And then routine monitoring and sometimes laboratory responses too. I'm concentrating on those because as a policy, in Kenya we are largely been end users. We have not been we have not been producing to my knowledge, a human vaccine that has gone into commercial use. Nevertheless, we are required the country to safeguard the public in use of whatever vaccine developed and tried elsewhere. Can we move to the next slide? So then, basically, I want to share with you that Kenya has to be careful about ensuring safety. So we have seriously and There's some noise. Somebody should. Okay. Clinical trials, which have been spoken about by my colleague just before. We have, if you go to the website, I think I've displayed this, I haven't, I will. We are very thorough about what we allow to be tested in this country. Sometimes negative innuendo implies that the guinea pig Kenya is not quite. There is actually a long checklist of 20. Oh, go back, we haven't finished yet. Yes, of 27 mandatory items that you must cover in the area of scientific quality, the ethical considerations that we have just had, and even safety itself. In terms of monitoring, we remain, at least the country remains vigilant in making sure that what is being done is proper, to the extent that a guideline, an elaborate guideline from 2019 for the safety and vigilance of medical products, and those include vaccines. Then, of course, you have the laboratory-based responses. You have heard about the AEFI, advanced events following immunization, and then, of course, there are what we call the severe ones. Next slide. I can't go there. Next slide, please. The slide has not moved. Yes. Just to share with you quickly the organizational infrastructure of immunization sort of surveillance in this country. Of course, the Ministry of Health, they are the national governance and financing body. They are responsible for making sure that we have our vaccines. But actual coordination is undertaken by a group called the National Vaccines and Immunization Program, which is somewhere near Kenyatta. Now, for a body like that to coordinate an important aspect of health, like immunization, especially in a politically and regionally complicated country like Kenya with 48 governments, they need quite a few, some help from outside. We have two committees that help them strongly in terms of oversight. The National Immunization Technical Advisory Group, and the other one there is specifically focusing on the issues of adverse events following immunization. The ICCI does not quite give oversight. The Interagency Coordinating Committee is a group of many agencies put together, at least help the national program by endorsing or helping fashion out whatever decisions they make. Then, of course, we go down to the counties where we have the focus points, and that's where implementation of the actual administration in terms of governance will take place. And finally, the health facility where there's delivery, I've given you that lot. I don't mean you have two counties. That's a representation of the counties. Go to the next slide now. Next slide, please. Yes. So just a quick word of the sort of the mandate of this body. So the NITAG, as we call it in brief, or KENITAG, we like using our country's name very well. It's advisory to the Ministry of Health on all policy issues around immunization. What to choose, when to give it, what the population to use, we research and advise. It also offers some sort of oversight, so that in terms of advising, it's now oversighting, helping the, I think this is what I've written here at night, it should be the MVP, oversighting the MVP matters that would help it in coordinating the national arena. The NITAG is also important in networking many stakeholders. Immunization is everybody's business, including the group that have posted us here. So our interest are now that as chair of NITAG, I've met you today. I'll include you in my networking. The next slide. The next slide is when it appears. It's yes, looking at the mandate that has been given to the National Vaccine Safety Advisory Committee. There's also the 7 things that they're supposed to do to provide recommendations on the continuation of for modification of existing policies on safety, to advise on potential and already identified vaccine safety signals, and to advise on issues of vaccine safety that have potential impacts on regulatory decisions, especially by the Operation Board and the National Policy Guidelines, to advise on the safety profiles and approaches to safety monitoring of new vaccines. So this group is a pretty busy. Like now, the pilot things that are going on, they have to keep an eye on things. The next slide. The other three things is identify the need for further data and policy making, so that they can advise that this line of investigation be mounted. Keep the authorities and the administration updated about the latest development, which may be within or without the country, and help determine any causal relationship between vaccines and the components. These are the aspects. As we know, these are very emotive things when there's an effect. Quite often, the what is recorded is death of babies or even adults, and that's the big deal. Next one. The interagency coordinating committee that I referred to, basically, its main issue is to endorse the activities of immunization, and also is part of the national advocacy infrastructure. Immunizations are given to healthy people. So, and healthy people, if they become sick from something that was supposed to stop them from getting sick, it's a big deal. To sort of mobilize the thinking of the people that getting sick might occur, but that's still part of the good that will come your way. It's an advocacy that requires everybody, including the 35 people that are on this call today. The next one. Next, please. Just so that you know how serious the country is, the map I'm giving you has a number of laboratories that are sufficiently complex in investigating just about anything that can constitute a vaccine adverse event in Kenya. And as you can see, the family that is participating in this is written on the left. There is the CDC, the Health and Demographic Surveillance System, that is in Philippi, the population-based infection surveillance. All those people have nice labs that can help us in what we need to do. This particular group coalesced together at the time we introduced the pneumonia vaccine in 2011, and they have made it strong. So this country is prepared, if appropriately deployed and funded, to investigate anything on immunization issues. Next. Next slide coming. Yes. As I got to close, I promise that I'm only talking policy and generalities because even the things I'm talking about the lab have been mentioned by the younger speakers before me. When you reach my age, you minimize the amount of you do because you may collapse. You're all familiar with the stuff I've put on this slide. In 2014, we had that report from my church, the Catholic Bishop. Tetanus vaccine is the birth control in disguise. You can access that. A year later, the Catholic bishops again, of course, the polio vaccination. As we are trying to end game polio, the society are trying to end game birth. And then, of course, there's a more recent one where now this was the WHO responding to a group of my colleagues on the issues vaccine. The thing about something for public good, as the economists have said again and again, you must never dismiss a member of the public who are themselves not sure that the good is what you are saying. It's our duty to make sure that we deal with that. So it's one thing to just have the hard science that you have had today, of being sure that the efficacy, the impact and all that, but you must listen to the consumer, the public. And when these things came around, we got concerned, those of us from the protection side of immunization. The next slide will give us an idea. Next. Yes. The Ministry of Health formed what we now call the Vaccine Testing Committee in that 2014 in response to that difficulty. And that group had a wide membership of scientists from the University of Nairobi, from Kemri, and other independent bodies. And all major religious organizations were invited. The Catholic Church showed up. The other ones, I don't recall that they ever came because I'm a member of that one. The secretariat of that was the National Vaccine Immunization Program, together with the Disease Surveillance and Response Unit, both units of the Ministry of Health. The purpose was to oversee testing of all vaccines meant for campaign. People had never had trouble with the routine vaccines, what we call routine, the ones to give day to day. People always think that when you bring people who have either already been vaccinated or outside the usual vaccination range, and you suddenly want to just abruptly vaccinate a large number of them, that's when eyebrows are raised. And in this country, our eyebrows have always been around fertility contaminants. So the purpose really to look at that whenever we have vaccines intended for what we call a campaign or a mass response. So far, the antigens or vaccine varieties that have given us the activities that we have enjoyed, or if you can call it enjoyed, are tetanus, the oral polio, meningitis A, which we launched for the upper part of the country within the so-called meningitis belt, and the human papilloma virus. Human papilloma virus, we have been concerned from the beginning. It is a routine, but knowing the emotive issues around it, we felt that we should treat it the same. So at the beginning of 2014, we decided that maybe someone would argue that our labs in Kenya may not be good enough to identify these impurities. So we benchmarked with the laboratory very expensively. I can't recall, more money than a professor can earn in 30 years of work was spent on sending these samples to Germany. And then we compared the same samples done in the public health laboratories in Nairobi, and we found a concurrence, a correlation of 100%. So we are happy, and everybody in the committee was happy that we can proceed doing it locally without spending the equivalent of 30 years professor salary. So we then have gone on, and from 2015 until actually now, to the extent that in 2019 we had agreed that I think we can now move forward and only do random checks. Now that we are testing a potential new vaccine, we might be advised otherwise, but we have submitted to the cabinet secretary that I think routine checks may not be essential because we have proved concept. The next slide is that little fellow thanking you for listening on her behalf. I think it's the guy looking at the hair. I think I'd like to stop there because I aim to talk of policy, to talk systems, and to talk governance, while my younger colleagues can say what they say. Thank you, Kwame.
Thank you very much, Professor Were. Thanks for the presentation. I think you've taken us through the fact that, well, clinical trials have guidelines, and of course, there are trials guidelines and the safety monitoring guidelines. I like the word that you mentioned to me, which I've not heard before, which is pharmacovigilance. I suspect that comes from pharmaceuticals and vigilance, which is basically lab-based pharmacovigilance. You say that there are 27 mandatory items that have to be checked, so the checklist seems very comprehensive. You discussed the organizational infrastructure of immunization in Kenya, and specifically, which I had never heard of again, which is the National Immunization Advisory Group, as an interagency coordinating committee. There's also the Vaccine Adverse Event Study Sites, 4 of them in Kenya. I think some are basically public sector, others are partnerships between government and other institutions. And I also like the fact that you mentioned actually the sensitivity that exists in this country regarding fertility control and its relationship with vaccine development. You are suggesting that the ability to gain trust through the use of scientific processes, expensive processes sometimes, but gaining public trust in vaccine development, vaccine deployment is an important thing. And you spoke about benchmarking with the lab in Germany, and that has resolved some of those problems that are here. So as a whole, we've gone through the economics, we've gone through the bioethics, and I think Professor Were has told us about what the regulatory infrastructure is in Kenya. So right now, I'll call upon the rest of us who have questions to ask, and we can do it in 2 ways. On the menu bar, right on your screen, on the menu bar right on your screen is a floating bar, and there's one that has a palm showing. So if you'd like to ask a question, please just click on that, raise your hand by clicking on it, and I'll be able to pinpoint ask your question to the panelists. But in the meantime, the other questions that were sent through the chat box, and I think I'll ask them at this moment. So the first question would go to 1 minute, please. This first question is about. The first question would be about. let me find it. Okay, the first question came from Joanne Obunga, and she's asking this question to the panelists by saying that the reliance on importation of vaccines has often led to suspicion and lack of confidence in their uptake. And of course, she cites the same question, the same controversy that Professor Were has mentioned regarding tetanus vaccination, and I think which was alleged as a mass sterilization program. So she then says that the HPV vaccine caused great controversy with reported adverse effects, side effects on young girls, and asks for any comment on this. So I think that would be a comment that would be made by Dr. Njuki and Professor Were. So that's, I hope you heard that question. So basically she's asking us to comment, given the background of controversies around sensitivity and fertility control, what are your comments around the HPV vaccine that was to be administered to Kenyan girls from, I think, from the age of 12 or thereabouts. So maybe you can comment about that, the ethics and all that. Then Steve Bogo asks a question, what sort of support is required to accelerate vaccine development in Kenya? I think that's also an interesting one. That should go to all of you. Vaccine development, I think there's a part of it that might be about the economics and public economics part. The others would be the bioethics, and the other one, of course, would be the infrastructure and regulatory institutions. So I hope that will go to all of you as well. And Mukonyi Watai asks, I think this would probably go to Professor Were. How many vaccines are currently under development? No, are currently being tested within Kenya? Oh, for COVID, specifically for COVID, I don't know whether there are any. And how many of them have been developed locally? And also based on previous experience of HIV vaccine, patent ownership, how has the country addressed the gaps that existed from that time? So the question is, how many vaccines, I think there would be some kind of licensing, of course, through regulation, are being tested. It would be good to tell us how many Kenyans are part of the testing and whether there's something about patent ownership and sharing of that knowledge. And the final one is, Joanna Bunga again asks, why are African countries lagging behind in research, production and distribution of human vaccines? Is it a capacity issue or what are the constraints? So again here, any one of our panelists will talk about why are African countries seem to be lagging, maybe you might agree or not, in the production and distribution of human vaccines, and is it a capacity issue or something else? So I'll reverse the order of presentations, and now I'll start with Professor Were. Professor Were, please answer any of the questions that I've asked of the three.
All right, I hope you can hear me then. Let me begin with Joan. She's an aggressive young lady. The safety of HPV vaccine has been a matter that's actually global, and we were not surprised, and we are happy that the Kenyan population were also concerned. If you go back, there are countries like Japan, which even withdrew the vaccine for a number of months before going back. Like every other vaccine, there are a number of side effects that we have listed, but none of those major lethal ones have been proved anywhere. So even those that had their disquiet have since gone back to using the vaccine. Though this is a vaccine whose impact is much later in life, so it's even easier to ignore, but we know with the amount of cervical cancer that we have here, we would still support it. So we have no serious evidence that that's proven anywhere in the world that it has a harm that was mentioned. The issue of cost, I can say a word actually. What is the support required is basically money. The scientists are here. On average, we know that it costs about $500 million US dollars, $500 million, to develop a vaccine from scratch. Now, $500 million US dollars is close to some national budgets in Africa and the other developing countries. So that's probably, in my mind, is basically the main issue. The vaccines, the COVID vaccines, yes, there are some which are being tried in Kavi. I know Professor Anzala and others are participating. I cannot say that they originated here, no, because the first antigens that we started trying on were elsewhere, so the origins were somewhere else. But our laboratories are participating, and therefore, within whatever they've signed up, which I do not know completely, they will have their intellectual property depending on what they've contributed and signed up to. But also that 1 or 2 are being co-developed in Kenya. I think I'll leave it there for the moment. If I receive another question, it can be asked again. Back to you. Kwame.
Okay, fine. Okay, thanks.
I think you're having too many of us on.
Yes. Can you please mute microphones? You can. Okay, thanks. Okay. So thanks a lot. So now I'll go to Wanjiru Njugi. I think there's two questions about to you as well. Please take your time to answer. Dr. Njugi, please unmute your mic.
Yeah. So I just want to mention about the point of HPV vaccine, about the side effects or adverse effects which we mentioned that were mentioned. And just like Professor Were has mentioned that I previously in my slide, you remember I mentioned about the groups I reclassified the side effects. So what the media and some social media were picking were what we call the anxiety and coincidental. So I just want to mention about the anxiety that I remember one person tweeting and saying that her girl was vaccinated and fainted and developed some kind of, she could not explain in clarity, which could make a symptom or a history to a patient, but she was saying that the side effect developed after the injection. So that is what I'm saying, that anxiety, because if you relate into the same school or the same group of the girls which were vaccinated with the same batch, because the vaccine are developed in batches, and then they are distributed so that we can be able to track back which vaccine was used and when and where. No other person was developing a symptom. So if I was going back to do what you mentioned as pharmacovigilance, to try to identify what really happened to that case, is that I would associate more to anxiety, because after day 2 to day 3 they were okay, but there were no other symptom. So they just preliminarily classify to that. However, on that point of accelerating the production of vaccine in our country, one problem we have is funding. Every other day when the budget is being read in our assemblies, you realize that the budget to the health is most of the time quite low to substantiate a program like vaccine production. So what we need to do is we need to budget more research setups, that is KEMRI, that is other agencies that are doing research which are producing these vaccines or the drugs, so that they can be able to fasten or create more quality production or more efficient method of developing these vaccines. So in my point, I would say the biggest problem away from infrastructure is funding. So we really need to see more donor money being put there, or more tax-funded programs, so that we can facilitate and fasten this program. Yes. Just back to you, Eric.
Thank you, Leo. There's a question about what should be done to improve the amount of vaccine production that takes place in Kenya. Could you answer? Could you go?
Yes. Okay. So, as mentioned also by Professor Were and Njugi, it's about all vaccine development is resources. Developing the vaccine from scratch, from the research itself, all the way as it moves up to the clinical evaluation, and also the vaccine production. It's all about the capital that has been put into play. Also, it's also there are regulation issues that could be, they could ease some of the regulations to allow farms to enter, especially now that everyone is, it's needed. So it's a constraint of the vaccine development is a constraint of time. You can remove some of regulations, because normally a vaccine would take more than 2 years But now that you need a vaccine as soon as possible, you can lift some of the regulations. Okay, back to you, Kwame.
Okay, thanks a lot. I'll go to the next set of questions since I haven't seen anybody's hands up. So let me ask the next set of questions, which was, okay, there's a question from Linda Okolo. I think that this is again to the medics. So the first one is, we are all vaccinated against TB, yet we still get TB outbreaks from time to time. So why is this the case? I think that's an interesting one for us to, for popular understanding of how vaccines operate and what their limits are. So that's Dr. Njugi and Professor Were, you'll answer that. Let me go to another question. Another question comes from Valentine, and he asks, is it possible to eliminate some of the vaccine testing procedures in the case of a pandemic to save lives? And if so, where do you strike the balance between saving lives and some risk of long-term effects? Again, that's to the medics. The second one, the third question is by Emmanuel. Emmanuel says, in what areas of medical research are we specialized as Kenya? I mean, does Kenya have specialization in some areas of medical research? In other words, do we have some specialization relative to other areas or relative to the world? Then we have Steve Mbogo. Of course, he does this. This has been asked. I think the next one is Mukonyi Kavaka. And he asks, do we have a National Research Ethical Committee, or is there an institution performing that role? Yes. And then Joanne asks about the interest, in the sense that in respect of donations towards research, there is never free lunch, because even philanthropists who support medical research are tilted towards certain interests.
Tommy, you're frozen.
Okay, I'm back. So let's go ahead. The questions. So this time I'll start with Dr. Head. Dr. Njugi, go ahead. Questions you could...
Hello?
Yeah, we are here. Can you hear me?
Yes. So I remember the first question was, why do we still have TB cases in the country despite having the BCG, that is the vaccine for the TB? And I'm not sure Professor Were will emphasize that detail because he's a pediatrician. But in the process, I would like to just mention that when I was talking about the vaccine, I said some things affect the vaccine. Which one? We're talking about the immunity. The vaccines are supposed to increase the body response towards infection to our bodies. So, for example, if you're given the TB vaccine and down the line your immunity goes down, and an example I gave is a kidney failure. I talked about HIV/AIDS cases. You expect the vaccine we give you at birth will be tampered by the immunity going down. Now, since the immunity is like the soldiers, it's like we are increasing the number of soldiers in your body so that you can be able to fight more. So, but when your body is weak, those soldiers also become weaker. So that is one cause, and that's why probably the researchers will come and tell you in future that despite the process of having the vaccine, the patient who have HIV/AIDS or cancer or cases like kidney failure, they will end up developing the TB. That is one cause. So the other question was mentioned was about I remember it's talked about whether we can increase or we can be able to tamper with some protocols so that we can increase the speed of producing the vaccine. What I would say that my foundation of the slides were about ethics. And the key word here is we should not tamper with any step or any protocol, even if we have pandemic, so that we can have the faster production of vaccine, because what we are doing is saving life. And if we tamper with the process, we might be destroying the life of those we are putting at risk during the study. So then I add up the question, what was the purpose of the study then? Because the persons who are put on the study are still human. So if we tamper with the process, we might be we shall be putting them at risk, which death now can be a net game for them, in the name of trying to fasten the process so that we can have a vaccine. So to me, that is not ethical. What we can do is that, and I've seen it now, what they're doing in COVID process, because I've been following closely with it, is that they are doing several steps in the same timeline. For example, they select a certain group whereby this group will be testing whether the vaccine is working. Then they select another group where they will be putting that, can this group be testing whether the drug is causing, or the vaccine is causing toxicity or is harming ourselves. And then the last one, whether it can be put into mass population. So the same timeline, but they are doing several steps at the same time. So that is workable. But whether for us to not to overlook or to underlook some steps so that we can have fastened the process, to me is not ethical. Yeah, thank you. Back to you.
Okay, thank you very much, Dr. Wanjugi.
We didn't hear.
We can hear you. Go ahead, Prof.
Sorry, I was trying to exercise my lip reading. It's not so good. Well, I just say two things. In the issue of the presence of TB, despite the fact that we are vaccinated, I think it's around the goal. Just about everybody, most of the people on this phone call have had TB infection, actually. I can assure you most others have. The approach is that the TB vaccine is effective in making sure that you do not go beyond just having had a little infection. You don't get into what we call the complicated forms that are beyond the lung. So we know that we intended to do more than that, and current research is going around having to modify it so that it can stop infection itself, not just stop serious infection. So we have plenty of benefits. 2 words on research. A lot of medical research in Kenya. I don't know whether Emmanuel wanted to know whether we are making invention research or we are making hypothesis research to find out how to use our tools better. But we have also research, even during this COVID issues, we are hearing universities pulling out ventilators and other equipment that we can use. So research has always gone on in Kenya. Let me give you a living example in vaccines. One of the leading groups in the vaccine discovery for the world is actually the vet laboratories of Kenya. So though we have not done as well in the human side, but we've done well, the capacity is there. The little matter of 500 million might be dollars, that is, not shillings, might be the big deal. I think what I did have something to do with whether we should eliminate processes. Not really. We can fast forward things where you do the stage 1, stage 2, and go to the human beings a bit sooner, but you cannot fail to do all the steps that Dr. Njiku mentioned. We won't let you, the people who are doing the ethics. There is, of course, a national body called NACOSTI, the national body which oversees all the ethics committees. And if you have something as big as a vaccine trial, you will have authority from the University of Nairobi, for instance, or Cambridge. Then you'll have concordance from the Ministry of Health. then you must get the final approval from NACOSTI, which is under education and sits independent of all these other bodies in a way. Thank you.
While you're still here, Professor Were, somebody's asked, Mwai has asked, what assistance can the Pediatric Association give to investors who are prepared to establish some facilities in Kenya, some research facilities in Kenya?
Well, I don't know that the association has the power to do, but the association is very loud in advocacy. If it requires that we converse to the Cabinet Secretary of Health, Cabinet Secretary of Education, if it requires that we chat to the universities to be the host for those sort of things, we can do. We are big in sort of insisting on having a seat at a policy level. So an investor who came through us will get a hearing. Thank you.
Okay, thank you, Prof. I'm coming towards the tail end. So somebody's asked, I think I'll ask all the panelists to comment on this. Please kindly comment on the issue of booster vaccines. Are they really necessary? I think that's one question. Let me ask a final one that I'd taken down here. Yes, the second one is from Kevin. And Kevin asks, if vaccine trials were to be conducted in Kenya, who grants the consent? Is it through delegated authority of the government or the individual persons who would have to personally consent? I think that's a good question. What they're saying is that if, for instance, I was prepared to offer to conduct, to be a participant in vaccine trial, is the authority of the Kenyan government required, or would the contracting parties be the test person together with whoever is testing? I think who gives authority for vaccine testing to be done? Is it government, or does that require the additional consent? So I'll start again with Dr. Njuki. Please go ahead.
Yes, I will start with the point of the consent about vaccine, and I'll give just a small brief story. When I was in India doing my undergraduate, and we found that there are a group of people who would want to join the research because of the token they are getting. So they are not going to consent because they are putting themselves into risk. To them, it's more need whatever comes after the research than whatever is being done. So you can see that's quite a critical point. And I would guarantee that even here in Kenya, there's a number of us who would say like, oh, I'm getting some money, so I want to go. But that is not the basis of the research. There is how we select participants into the research. And once we select them, we are going to give them a consent document. That is the legal document abiding the researcher and the candidate. So that for them, they understand what are the procedures to be done, what are the outcomes, and what can happen in case, because you're saying this is a research with the plan. So there's a number of adverse effects we don't know with the vaccine can happen to us, because COVID-19 is a new disease to everyone globally. So we don't know too much. We can say that if you get this, you can go to this. So that is the binding law. It is not really a government law or someone else, or it's an individual choice that I consent to go forward with this research. Where the government is coming, or other regulatory authority, like what we call REC, that Professor Well was mentioning about bodies in Cambridge, University of Nairobi, etc. The job is to make sure that the research, the intended outcome are there to be met with the process laid down, but there is a protocol of what is laid down so that we don't bleach the contract with what we intended to give out. So that is the key word. So the consent is individual.
Okay.
Yeah.
Okay. Professor Were, do you have anything to add?
One word, because you wanted to know about the boosters. Boosters are required from time to time, not in all vaccines. When somebody is vaccinated, over time, the power of that vaccine fades away from time to time. and you need to just revaccinate them with a smaller schedule, a smaller dose, and you wake up the memory of the vaccine again. This is not necessary for all. For instance, if you have a disease which only occurs in the first 3 months of life, you don't need to boost that person at the age of 60. If you have a disease which can affect somebody at any time in life and is of high impact, then you need to. We boost a number of diseases basically because of the potential impact later in life. So boostering is important, but not for all, so it needs to be planned and scheduled. The country has a good schedule for that. Let me just say something about the issue of vaccine trials. I mentioned Kwame didn't give me enough time to talk you through the 27 steps, things that you need to satisfy as to make a clinical trial. At another time, I'll persuade him to allow me to do so. They are very demanding and rigorous. That for you to do a vaccine trial is probably the highest level of clinical trials because you are using something that is you're giving it to the people who are well. So you have to adhere to those. Convince the ethics committee. Convince the nation. I'll give you one final example. When you are going to do a trial of the malaria vaccine that is going on, we delayed by up to 6 months because some aspects of it are actually political. And we needed permission from the cabinet itself chaired by His Excellency. And we listened and waited until that came our way. If nothing else, the controls that are laid down in this country for clinical trials are heavier than many places I was tracking myself in my many years around medicine. So all those are followed. Thank you.
Most of the questions we received today are on the medical side. So again, Professor Were and Dr. Njugi, another question from you from Judith Museve. She's asking, is it necessary to test the strength of an individual's immunity before they become participants? She's saying, especially with the COVID-19 vaccine trials. So to paraphrase that, before anybody participates, or rather, are only healthy people required to participate in vaccine trials, right? Are there pretests to ensure that somebody can participate in a vaccine trial related to the health? So let's start with Dr. Njugi again, and then we'll go to Professor.
Yes, like we have just mentioned that when we are going to do a research on that is trials for the new trial for a vaccine, we must make sure that what are your baselines, what are your normals, so that when the vaccine is inoculated into you, then we can now know what has changed or what are the reflections in your body system. So it is true, we must test how normal you are, so that we put it in place that this is how your body was before the vaccine, and this is how it is reflecting after the vaccine. And the changes is what will determine whether the vaccine is active, safety of it, and also whether it's effective. So it is true, we test for the baselines.
Okay, Professor Were? Having said that, I think Dr. Njugi has put it well. Remember, weakened immunity in the individual is not a reason not to vaccinate them. In fact, after we have tested and confirmed that it works very well on the absolutely healthy, many vaccines we then give them a run on those who are immune depressed already. We have established now that, in fact, the people who have HIV infection, even they benefit a great deal from the pneumonia vaccine. They benefit a great deal from a number of vaccines, including flu. So the fact that we know at the beginning, but don't mix it with the fact that because you are immune depressed, we shall not vaccinate you. We just need to explore further, after the original group, the benefits, if any. For instance, if you wanted to exclude malnourished individuals in this country, sometimes throughout 1/3 of our children are slightly malnourished. You would be excluding them from vaccination. So certain levels of potential low immunity, we look the other way, but the major ones, we also explore to make sure that we don't exclude those people from benefit, because they're probably the ones who need protection more than those who are absolutely healthy. Thank you.
Thank you. Okay, well, we're coming towards the end of our questions. I haven't received any more questions, but yes, Professor Were, I promise you that we'll have another opportunity for you to explain the 27 steps. I think we can open up another conversation separately on how to do that, but basically those 27 steps are important. One question that I'd like to ask, I'm asking the medical professionals, Professor Were and Dr. Njugi, as we close, is this: has somebody considered, I think you understand that COVID and an emergency such as COVID comes with many different things. One political thing that I think is going to get much stronger and which makes these conversations necessary and public education necessary is the view by some people, quite apart from their own concerns about the effects that vaccines would have on their own bodies, the view that right now, throughout a human being's life, by the time you're 40 and above, you've had repeated vaccinations for so many things, and many people don't understand what the total effect of all these vaccines working together, I mean, or rather the effects that they have, one working against each other, would be, and whether that in itself is a good thing or not. Is there some research, or how would you advise people who are naturally concerned that there's too much medication related to vaccines coming into the body, and their mixture over time might have some adverse effects in one generation or the other? And so you can give me your views about that and whether you've had that concern in Kenya or not. I think it's not something I've had in Kenya, but there are people who are concerned about it in other parts of the world, and it's a rising thing for movements that try to convince, whether they are members or convince other people, that vaccinations all put together might have adverse effects. And then you can have your final comments as well. So I'll ask each of you to make your final comments. I'll start with Leo, and I'll come back to Dr. Njugi, and I'll ask Professor Were to finish. Leo, do you have any final comments?
Yes. So in closing comments is that part of what Kenya could do now is to allocate more resources to agencies like KEMRI and the advisory team, so that they can be able to build that momentum. Because we have to participate either directly or indirectly in the vaccine development process. Back to you, Kwame.
Okay, thank you very much. Dr. Njugi, your final comments on the question about the multiple effects of.
Okay, what I would say is that science is made of inventions. So we are continuing inventing new things. However, about the maybe overloading our body, because that would be, I think that's the most appropriate word I would say, is that our body are made of so many components, and these vaccines are creating what we call antibodies. And the memory in our body is so wide, actually so wide, to cope up with as much as it can be fed, as long as it's safe and secure to be within the body. So I don't, maybe future research would do that, so that we can be able to ascertain, because we have seen that in earlier ages, the number of vaccines which were given to small babies was not the same. We have increased, or we have enlarged the scheme or the schedule today. But however, just the baseline is that our body are capable of holding as much as possible, as long as it's safe and efficient to our body. However, about the closing remarks, I would say is that, like I was showing you the graph of the lifeline of a vaccine or vaccination, is that at the first we have this we are calling the pre-vaccine, and everyone is worried. Everyone is worried about their life. Everyone is worried about whether the vaccine will be found, and the disease prevalence is very high. Then we go to the next stage where the vaccine is found, but now the disease is still also high. But as the vaccine go together, they crisscross somewhere up to the point that the disease goes down and the vaccine rate is very high. Then we go to the third stage whereby the disease prevalence is very low, but now the side effects are still there. And now here, it's where let me just use the word propaganda, but it's not useful in science, to mean that people now start spreading the wrong term of the vaccine. And it depicts the momentum, and the people stop taking the vaccine. So what I would say is that I would like the people who are giving the falsehood or unfounded information out there to let the medic to correct it. That is what I would advise. And then we need to give more information about the vaccine, the new development, the new changes we are making, and how safe they are, so that everyone walking around is as safe as he can just snap his finger and say, like, you know what, I just went to get a H1N1 vaccine, or just a COVID vaccine or HIV vaccine, and I'm okay. That is, the more information we give, the more comfortable the people are, and the more easier we can be able to move on with the vaccine. Say that doesn't mean that the vaccine doesn't have side effects. We just have to know which they are and what they causes, and then how can we rectify that, so that is part of the information I'm saying, so that at least everyone is at a comfortable plea with most useful information out there. Thank you. Back to you, Kwame.
Thanks, Professor Were.
Another good idea on the last speaking. They might speak for too long. One word on the first point, the question. One of the requirements when you introduce a new vaccine is you prove that it can be co-administered with others without changing their impact and effect and increasing even side effects. Number two is that as we are introducing the 13th vaccine, I think 14th in Kenya, we also made sure that the vaccine that is coming has been proven by the manufacturers that it can be co-administered without cross-interfering with any other. So that's a requirement. Even if you release 50 vaccines at one time, primarily we must make sure that they don't cross-react. Where necessary, we space them out so that one has given the other one space. But co-administration is a fundamental primary requirement when you are developing. I'll close this by saying that for me, the story about immunization being the second best to water as a public health concern has been told and told again. The story the first presenter gave a nice conversation about vaccines being probably victims of their own success. And what I can say for people sitting here is that I welcome you to the war of keeping vaccines relevant in our arena and protecting them to whatever extent that you can. I will do my end on the regulatory side of things, on the politics. You do your bit on the financial side. Give us enough money to develop them here. We shall be happy. Thank you, Kwame.
Okay. Thank you very much. I have to say that, yes, there was some injustice to Ethel Makila, who asked a fantastic question. And the question is, looking at the existing budget documents, there is a clear gap in terms of allocation of resources to research. A large portion of the health budget is towards capitation of health workers in KMTC, as opposed to research activities. What can be done to enhance the use of the resources that we already have? I think all our respondents, all our panelists should answer that question before we close. I apologize that for my oversight over it. I did not look at it, but I think it's a very, very interesting one. Because in addition to vaccine and medical research in general, I think there's a budget question and there's a role for government. Economists are prepared to concede that. However, if you look at... Yes?
Oh, can I say my 2 words? Because I need to go to the washroom, being my age.
Yes, please.
That I want the politics of the country to go back and look at the Abuja Declaration, go back and look at what we said in this nice place called Addis Ababa, and talk about the 2% GDP that we should go to research and apportion it properly to different ministries as a beginning point. Thank you.
Oh, thank you very much. Dr. Njuki?
From my side, I don't think I'll add, as a professor has concluded, is that what we just need is to add the funding, the finance which are going to research. It is true, it is below par, very far into other countries, and we just need to increase is to it, and also the research foundation which are given this amount of money, they also need to come up with better detailed programs to explain exactly where we are given this amount. This is what we did, and this is what you are missing, so that the gap can be substantiated. So to me, more funding.
Okay. Leo, do you have anything to say before we close?
Yes. So as economists, we normally say that you have to fund the needs. You assess the needs, and then you fund those needs. So Makila has raised a very important question, and given that there is reporting now that we saw from the supplementary budget that was done that KEMRI had been allocated a little resources. So what we need is more resources to match up the needs. And we don't per se say that we have to give this percentage, but we say you have to match those resources with the needs. Okay, Kwame, back to you.
Okay, fine. Thank you very much, ladies and gentlemen. So I'll just complete with 2 points. The first one is, yes, the scope for increased research is important. Some of that research can be, and medical science tells you that knowledge in vaccine development doesn't matter whether it comes from outside Kenya or inside Kenya. I think it's useful for preserving life, so we should be open to it. The second one is that there's specific regulations and protocols which all justify the existence of those rules and institutions. I think those institutions and rules should be strengthened. But the impression I get is actually that the public is unaware, but they are working fairly well. I mean, decently actually, because it's a fairly elaborate process, as Dr. Jugi has told us, and as Professor Were has confirmed. Definitely, it's not as if anybody walks in with a vaccine or what they call a vaccine and starts to conduct tests in Kenya. There are significant, they're important hoops that have to be jumped, and some of those are informed by medical science. They're not just built off their own. The third point is the question of the budgets. I think how we design budgets is important itself, because most of the claims we see, an important one coming from what Ethel said, which is that you cannot just spend money funding recurrent budgets. You also need to fund the research, and how we build those research based on the commitments that the government of Kenya has made is a useful thing to consider. So there's a message to be said for advocacy. There's a message to be said for the design of that. But one of the things that I know, for instance, is that the government of Kenya extracts significant money from excise taxes, and that's as it should be, but most of that money is never directed to research for the purposes of alleviating. So we claim that we have excise taxes on some products, whether it's alcoholic beverages, tobacco, and many other things, but we never push that money towards medical research, and perhaps that's the way it should be to begin to bump up the amount of money that goes into medical research, so that some of these vaccines could come in, but also we develop the institutional platforms. So my great thanks on behalf of the Institute of Economic Affairs to Dr. Njugi, Professor Were, and Leo Kemboi, who presented fantastic presentations. We'll make sure that a summary of this conversation is available, but the presentations will be available on our website immediately after this. If you're looking for it, please go for it under webinar number 8, which is our 8th webinar, and so you can find it up there. I'd also like to thank all the guests who are in here, all 43 or 44 of you. Thank you very much for spending your 2 hours to be here. I'd like to let you know that over this week, the IEA will have 3 other webinars. So on Wednesday tomorrow, we'll have a topic on discussing and listening to the voices of teachers from all over the world. The second part of it, we had a first part last week, and we have teachers from all parts of the world: South Africa, the United Kingdom, Kenya, and Nigeria. We'll have them speaking at 10 o'clock in the morning. So that will be 7 a.m. GMT tomorrow from 10 to noon in Kenya. And then on Friday at 3 p.m. we'll be asking Dr. David Ndii, who's one of Kenya's public intellectuals and leading economists, to discuss his views about what a lifeline fund is to support businesses that are facing, micro and small enterprises that are now facing a significant shock on account of the fact that we have to stay at home. That's a conversation that will start at 3 p.m. on Friday. And at the same time on Friday, we'll be discussing what the effects, early in the morning, we'll be discussing what the effects of COVID-19 would be on trade around the East African region. We'll provide you with the time for that. So please look at our website and follow us on the social media pages so that you can have, you'll be informed about when these start. But that stated, thank you very much, everyone, and have a good morning or good afternoon. And thanks for supporting the work of the IEA. Thank you very much.